Thanks again for being here. This is cool. I love this because I get to talk to all my favorite professors.
I'm jealous. I want my own show.
You should start it. You could come. Well, you could be the first because you had the idea.
We'll talk afterwards.
We'll talk afterwards. Okay. Welcome to another episode of the Zach Hiley Show. Today, I have the honor of being with Dr. Oxman. So, Dr. David Oxman is a critical care doctor and associate professor of medicine here at Jefferson, as well as the program director for the Critical Care Medicine Fellowship. He went to medical school at Temple, where he also completed his residency in internal medicine. He completed 4 fellowships, which is unusual, I think, 4 fellowships in infectious diseases at Tufts, surgical critical care at Harvard, medical critical care at Hahnemann, and medical ethics at Harvard. He is currently the Ethics and Professionalism Thread Director in a student group led by Dr. Oxman, I also had the personal luxury of being in a student group led by Dr. Oxman, where we had discussions around being medical students and our hospital experiences. Welcome, Dr. Oxman.
Zach, it's great to be here.
It's great to have you. So, we usually start these episodes by talking about statistics around your specific specialty, critical care, and then if you have any insights or thoughts around these, you can let me know. Okay, so the median attending physician salary across the U.S. is $339,000, while critical care is $366,000. The average hours worked per week across the U.S. is 51 hours per week, while critical care is the winner at 67 hours per week. 59% of all U.S. attendings are happy compared to 53% of critical care attendings. 40% on average, with burnout at 56% in critical care. 41, when physicians were asked across America, would you choose this same specialty again? Generally, the average was 41%, while critical care was 44%. The Step 2 score average is 246 across America, with critical care being 247. Any thoughts, anything jumping off the top of your head from those statistics?
Whenever we talk about critical care, the first thing we have to remember is that it's a very heterogeneous specialty. There are many different pathways to critical care. You can become a critical care specialist through internal medicine, through anesthesia, through emergency medicine, through surgery. And each one of those careers are very different, different training pathways, different work environments. So the first thing I react when I hear those numbers is that's a conglomeration of many different types of work experience.
So in your experience, do you think the numbers are higher for you personally or lower, in whichever one you want to talk
and then there's obviously, and this is true of many specialties, the academic versus private practice divide. There's the regional variations as well. But yeah, I mean, I think they're ballpark numbers.
Yeah. So just to be clear, because I didn't know this either, so you can go from surgery to critical care. You can go from internal medicine to critical care. Can you go from like pediatrics to critical care?
Oh yeah, absolutely. I forgot pediatrics.
Wow.
So critical care is not a residency program; it's a fellowship, right? So you have to have a primary specialty first.
Yeah.
As we'll talk about later, I mean, critical care as a separate discipline is relatively new. I mean, really since the 70s and early 80s, critical care units themselves didn't really start till the 1960s, early 70s. And there are some countries, I believe in, for example, Europe and some other countries, you can go into a critical care training program right out of medical school. But in the United States, it's a residency first, your primary residency pathway, whether that's medicine, pediatrics, or anesthesia, and then a subspecialty in critical care.
I see. Okay. And that may change, of course, where you're practicing as an attending based on your previous experience, whether it was the pediatrics or internal medicine or surgery.
Right, exactly right. So if you're usually if you're a pediatrician, you spend time exclusively in the pediatric ICU. If you're in a community setting, you might be doing both surgical critical care and medical critical care. In a quaternary or tertiary center, you're usually in one or the other. I should also mention neurologists also become neurointensivists as well.
Oh, that's cool.
Yeah.
So let's get right into it. I want to talk about your other stuff in your career because I think it's really interesting, especially your ethics. But let's start with kind of what the majority of people want to hear about is, what is critical care?
So I think critical care, when you think about specialties, right, they're sort of defined by either a patient demographic,
Mhm.
an anatomical area.
Yeah.
Critical care, I think, is interesting. I guess it's kind of like emergency medicine. It's defined by a practice location, right? Specifically, the intensive care unit. Not to say that critical care can happen in many different settings, but primarily critical care specialists spend their time in the intensive care unit. So critical care, I guess if you wanted a definition, would be a physician who specializes in caring for the critically ill or people who are facing life-threatening illness. And there are different ways you can define that, usually by organ system failure of one kind or another.
And what was your journey to critical care? What was your journey to this, other than the 4 million fellowships you did?
My journey to medicine in general was a little bit unusual, and then I think to critical care was probably a little bit unusual.
Let's start at medicine.
So yeah, I was not a science guy. I was a humanities guy. When my college roommates hear that I ended up in medical school, they can't believe it.
Really?
So I took 2 science classes in college, Man in Nature and Space Exploration. I think I had a B- and a C+.
Man in Nature? What is that? How to survive in the wilderness?
No, it was like science classes for people who don't want to take science classes.
I see. Okay, good.
And then spent some time trying to figure things out, and eventually ended up in post-bac and went from there to medical school. And I didn't start medical school until I was 29.
Wow. What led you to medical school? What is it? The time when you were spent figuring out? Was it an event? Was it an experience? Was it a volunteer thing?
Oh man, how long do you got?
I got all the time in the world.
I think several things came together. I think one, first and foremost, I was looking for something very compelling and meaningful to do with my life, a calling, if you will. I think I was also becoming more interested in science, but also, humanism in science, which I think medicine is the ultimate expression of humanism through science. And then, the personal factors too, you also look like, okay, well, it'd be nice to have a job that you like and is actually remunerative, and what could be better than medicine?
It's I like that you say this too, because it's the non-traditional pathway, which I think is becoming more and more popular. I didn't start med school till I was how old am I now? 28. 24.
Right.
And I took 2 years off, which is the average now. I think the average age of a starting medical student is 25, right?
I don't know,
I
but
think it's 25.
I fully support the non-traditional path. I mean, not there's also a place for people who knew from the time they were 6 years old that they wanted to be a doctor. Not to knock them, that definitely was not my path.
So you're in medical school at 29. How do you get to, because you do an internal medicine residency, right? Did you think in medical school critical care, or did you think in medical school medicine?
I think the first choice was, do I want to be a surgeon? Do I want to be an internist or something else? Yeah. And I was definitely drawn to internal medicine. I think like most people are drawn to internal medicine through, you kind of find your people, right? And you find what you like to do. I remember, I think everyone liked their surgery rotation. I remember liking it, but at the same time, liking it and really feeling like I have to do this is very different. And I just enjoyed the intellectual challenge of medicine. I also enjoyed the sort of humanistic parts of internal medicines. So that was a pretty easy decision to go in internal medicine. From there, I didn't really know. I think I found people that I liked and admire in infectious diseases. I think infectious diseases is a very compelling specialty, but also just a compelling thing to study because of its not only the medicine, but the social aspect of infectious diseases. So I sort of settled on that. But I also enjoyed my time in the ICU very much as well. And I had this vague idea that somehow, some way, I would combine them, but I had to figure out later how to do it.
So was it, again, deciding these infectious diseases, was it just kind of through your rotations on your internal medicine, you said, you know what, I love these ID docs, this is kind of who I want to be?
I think it was partly that. Partly is like if you had to give me an internal medicine textbook and say read about something, that was the chapter or the section I turned to first. I found that the most interesting.
Got it. So you're in your infectious disease fellowship, and then you get interested in critical care during the infectious disease fellowship?
Before I started my infectious disease fellowship, I worked as a hospitalist.
Oh.
And I had a unique setting where I spent a lot of time actually in the ICU as a hospitalist. And I was like, oh, I really like this. It didn't make me not want to do infectious diseases, but it made me want to really find some way to combine the two.
Got it. So we go from IM residency to hospitalist to infectious diseases fellowship. What's next?
So then I had to convince my infectious disease fellowship program director that I could take a year off and do a critical care fellowship.
Wow.
And for weird reasons, it was a surgical critical care fellowship,
Yes.
which is not it's not the typical pathway for an internist. But I had to be in a certain city, and I had this opportunity at Brigham and Women's Hospital. So I did that, and that was great.
Yeah.
And then I stayed on in Boston working as kind of combining infectious disease consultation and surgical critical care.
Wow.
I was attending in the trauma ICU and doing infectious diseases. Wow. Yeah, an interesting combo. And then because of the unusual path I took, and this is getting sort of deep into the weeds of how board certification works in critical care, I had to complete a medical critical care fellowship.
To get a board certificate?
Right, because the pathway is that if you're a surgeon or an anesthesiologist, you can do a surgical critical care fellowship and get board certified. Yeah. But that doesn't work for a medicine person. And it's actually a good reason because it's different. It's very different. So I went back after being an attending for 2 years, went back and did a medical critical care fellowship, which was great at Hahnemann, and then took it from there.
Wow. So you've done all these fellowships. Where does the ethics come in?
So again, I said at the outset, I'm sort of a humanities guy, and so medical ethics and medical humanities was something that always interested me. And I wrote during medical school and residency, and then when I was a hospitalist in Boston, I actually had the opportunity to do a fellowship while I was working. It's like a part-time fellowship at Harvard in bioethics.
Oh, cool. So this was while you were an attending in infectious diseases?
No. This is before, when I was a hospitalist.
Before?
Oh yeah.
Okay.
Yeah, I was a hospitalist, and I had this opportunity to do this ethics fellowship part-time. It was geared towards working physicians and nurses and people in the medical. Actually, no, there were some lawyers too who sort of were working and also doing this fellowship at the same time.
How difficult were all these different fellowships? Was there one that was way more difficult than all the others, or?
Well, they all have their challenges. And then you also start your wife looks at you like, okay.
Because this is, how many years of training is this going through?
Well, less than a neurosurgeon.
Yeah. This is true. This is true.
I had 3 years of internal medicine, 2 years of ID, and 2 years of critical care. I don't count the ethics because I was working during that. So I guess it's the same as a neurosurgeon. So that's 7 years. But it's also the same as, someone who wants to be an interventional cardiologist.
Yeah.
Right?
No, wow.
Yeah.
Did you find yourself being pulled toward, because now you're solely, a critical care doctor, as well as you'd have your ethics commitments here as well. Was it during these fellowships where you found, critical care seems to be the one there I'm fit best at?
Yes. I still love infectious diseases. And there are some people who, first of all, there are very few people that do infectious disease and critical care, but it's a growing number. And there's some people that are able to continue to combine practicing both specialties. I practice a lot of infectious diseases in the ICU, and I always think of myself as an ID guy, just because of the way I think, and there's a certain
spent 2 years there.
Yeah, and there's a certain approach I think infectious disease people have, but I don't.
Were you in the woods? Sorry, go ahead.
But I don't do consultations, and I don't have a clinic. And frankly, there's a lot of aspects of infectious disease that I just can't keep up on.
Was there any aspects kind of when you're making this decision, because it's a decision, right? To kind of drop out of the ID attending field, even if you're thinking about it during the ICU.
Right.
Was it lifestyle? Was it just it wasn't as academically or scholarly interesting?
One is that it's very hard to find a job in both, right? So for example, most internal medicine people who do critical care do it through the combined pulmonary critical care fellowship.
Yeah.
Which is interesting. That's kind of a fluke of the way critical care developed in the United States. But that's like 80% of internal medicine people who are certified in critical care. So those people can, finish their fellowship and open up a job listing and find a job, combining outpatient pulmonary and inpatient critical care. It's very common.
Yeah.
I could not do that, right? Because that job doesn't really exist. You have to kind of make that job.
I see.
And I made that job for 2 years, but then when I moved to Philadelphia, it becomes very hard to make that job for a lot of reasons. And also, frankly, I think I was becoming just more focused on critical care. And this is, personally, the lifestyle worked a little bit better for me, and also remuneratively, it was better.
Yeah.
But I don't think I would have done that had I felt it was just those things all lined up.
And these are good things to talk about. I hate the taboo around finances and things like that, because these are things we're going to be dealing with for the rest of our life. I wish there were more courses in medical school about these kind of things. I don't know. It's one of the reasons I'm doing this podcast, right? One of the reasons the first statistic I say is salary, because these are important things that are going to have an impact on your life and your family. And I wish it was talked about more, I guess.
Yeah. And I think that stuff should be, dragged out of the closet, so to speak. I also think it's important to put it in the right context for medical students. Number one, because, obviously money isn't everything, but also the statistics can be very misleading because there's extremely different pay based upon your particular clinical situation. As an academic intensivist, I bet you there's some private practice infectious disease doctors that make more money than me, right? So you have to take those things with a grain of salt.
And the cliche, I think, is true as well. You kind of have to do what you love, especially if you're spending 50, 60 hours a week doing these things, right?
I would agree with that. I think someone once explained to me that your choice is like, it's like a stew. You're creating, like, some people want a little bit more pepper, some people want a little bit more salt, and everyone has a slightly different combination of love of that thing and personal considerations that is right for them.
Yeah, and the awesome thing that I've learned, speaking to more attending doctors as well, is when you're in this position, your schedule isn't cookie cutter, right? Your schedule isn't the exact same thing as other attending intensivists across the country, right? You can do academics, you can do research, you can do more outpatient, less outpatient, right?
It's very different. Absolutely. That's another thing I think medical students have to recognize, is that two people in the same specialty can have vastly different schedules and salaries and work environments.
Yeah, and this is something I had no idea. For example, I thought when I first started medical school, everyone who was a surgeon was in the OR 5 days a week.
Right.
That is not true at all.
Right. Exactly.
Not true.
Exactly.
It's crazy.
Exactly.
So what is your schedule like? Maybe you could talk about an average week.
Right. So for an academic intensivist, usually the way you work is you're on service. When I say on service, meaning and attending in the ICU a week or 2 weeks at a time. Sometimes there's a weekend and sometimes there's not. Interestingly, I would say on average in academics, a full-time FTE, academic intensivist, probably works only about 26 to 30 weeks in the ICU. And then the rest of the time is spent in their administrative, research, educational activities. Now that can be very different than the prior. I for 1 year before I joined Jefferson, I worked as a private practice intensivist. And you say, well, what's a private practice intensive? Basically, this was, I was working for a group that staffed different community hospital, ICUs. Like the hospital would contract with this group. It's a very similar to the way community emergency medicine or even some community anesthesia programs work, where you work for this group and then they contract with community hospitals rather than being directly employed by the community hospital. In any case, and that was a straight up number of shifts a month. Like I would work 15 shifts a month or 12 shifts a month.
How many hours or shifts is it?
It can vary. I mean, some of them were like 8, some of them were 12, some of them were overnight.
Wow. Okay.
Yeah. And that way it's very much like an emergency medicine type of.
No medical students under you during that time?
No, actually, we had. So there's when I say community, there's a variation community. You can have a community academic program, right? So a hospital that is not necessarily affiliated with a medical school, but has a residency program, has students from a local medical school rotate through them. That would be a community academic program. And one of the hospitals I worked at was like that. I don't think I had students, but I had residents.
Got it. So when you have this, so right now, if you have a week or two in the ICU, is that a week or two a month? And then you just spend the other week or two kind of as academic research?
Yeah, basically.
Got it.
Yeah.
So, and what are these other academic, specifically to you, that you're doing?
Well, everyone else is obviously different, right? So there's be some academic intensivists who may be, doing a lot of research, right? Who they may have grants, and they may even have labs, or they're doing outcomes research and are working with large databases. So that's one thing. I do some clinical research, but I would not call myself a researcher per se. I do.
What does an average day then look like? So I guess we should split up the days based on the week. Let's say, what's the average day when you're in the ICU?
Right. So great. Come in around 7:30, 7:45. Talk to my residents and fellow. What's going on this morning. And then we start rounding first on our new patients. Rounds probably go from, I try to be quick and efficient. So rounds probably go from like 8 to 10:30.
Nice.
Some attendings may take longer. Then we, again, and that's if nothing's crashing and burning. And then there might be some procedures that have to be done, and there are notes that have to be written, and then there's maybe we have some time to do some teaching, and then when there's new admissions, and bing, bam, boom, it's 4:00, and you're doing evening sign out, and hopefully, as an academic attendant, get out of there not too late.
That's not bad. That doesn't sound too bad at all.
No, it doesn't.
That's nice. And then let's talk about like an academic day.
Yeah.
Say you have a teaching day. What is a teaching day like?
I joke with my friends who are in the humanities. I say a part of my job looks like a doctor, and the other part looks like an English professor, right? So I'm sitting in my office, and I'm either working on a manuscript, then I have to go teach a lecture, work on some administrative thing. And frankly, for me, I have a great setup in that it's very flexible.
Got it. So it's kind of whatever the focus of the day is, kind of thing.
Right.
Okay. And the ethics portion, is that, are you scheduled for certain times, or are you just kind of pulled in? So, I mean,
my interest in clinical ethics is both as a scholar. Right. I write on ethics and medicine topics, so I spend a lot of time doing that. Teaching, right? Teach a couple ethics courses to students, and always looking to do more on that. And then there's this thing called the ethics consultation service. So every major hospital has an ethics consultation service, and it functions, similar to, say, a cardiology consultation service. You got a cardiology problem? Call it cardiology. You have a sort of difficult ethical moral dilemma that that has arisen during the practice of medicine that you can't quite define or you need help with. You call it the Ethics Consultation Service. Now, we're not as busy as the cardiology.
I would hope not.
No, because it's a good thing because it's all volunteer. And
really?
Well, at Jefferson it is. We can have a conversation offline about that. Most places there is not, but at Jefferson it is volunteer. So I have a cadre of very, very dedicated, brilliant clinicians who help me do ethics consults. So we may only have a few a month, but sometimes we have calls, and they always seem to come up on Friday afternoon at 4 o'clock.
And are you a 24-hour call for these ethics?
Yeah, I mean, they're very rarely someone's going to wake me up at midnight for an ethics call, but that has happened.
So how does it work? So do they put a consult in Epic and then call you?
Yeah.
That's what they do?
Yep.
Wow. And then you meet with your team, say an issue comes up.
Right.
And then can you just make a decision right there in the moment, yourself?
Well, I mean, we can digress, talk a little bit about how ethics consultation works.
Tell me.
So I think the first misnomer about ethics consultation is that there's this secret cabal of people that somehow make decisions for the doctors and patients. Right. No, that's actually the furthest thing from the truth, right? We are sort of an analyst and advisor. So most of the times when we get an ethics consultation, doctors or nurses or sometimes even patients have this vague feeling that something is not quite right. They can't put it into words, but they have this feeling that something's wrong, or something needs to be discussed. And we help them put it into words. Yeah. There are actually, 4 or 5 main ethical consults that occur in the hospital, and we help them analyze it, look at the issues involved, look at some of the specifics involved, and then help them arrive at a sort of ethically and practically workable solution. Sometimes we mediate with conflicts between staff and patients, but ultimately the decision making is the final say is up to the doctors and the patients.
Wow. Could you tell me 1 or 2 of these? You said there's 4 or 5 things.
Yeah, I'll give you an example.
Yeah.
So one of the common calls for ethics would be you have a patient who's incapacitated for whatever reason, maybe due to medical illness or due to psychiatric disease, and they need a medical procedure, and they don't have the capacity to make the decision. How should you proceed? And that depends a lot upon what the procedure is, how effective it is, what are the practical implications, so forth. Another one might be sort of similar. We have a lot of patients increasingly who are what we call unrepresented, meaning that sadly they have no one to speak for them when they do become incapacitated. And how do you make decisions about medical care in that situation? Lastly, I think one of the most stressful sort of situations for medical professions is what we call non-beneficial care requests, what we used to call medical futility. The patient or the family is asking for something. Usually this comes up in the realm of life support and life-supporting therapies that the doctors don't think is beneficial, quote-unquote futile. And how do you manage that conflict?
So you just kind of have to... I'm interested in diving deeper. So if a patient's family comes and says something like, we want this care to be done, but the doctors, the teams, they've all decided medically and based on, the information that they have in hand that this is not going to help them one iota, right? It's not going to help them. Do they come to you? Does the patient's family come to you and say, listen, we want something? Because I'm assuming the doctors would go to the patient and say, patient's family and say, listen, we don't think this is a do. And then I guess you come in if the patient's family says, we want something done, we're going to go talk to someone.
Like most ethical problems, I'd say most of the time, doctors are able to resolve these conflicts themselves through, persuasion, through mediation, whatever. With the non-beneficial care requests, the ones we most often see is when the stakes are high. Usually it's a situation where someone is on life support that with a very poor prognosis for recovery, and the team is concerned that it's not only non-beneficial, but also causing only pain and suffering.
I see. And can you just give me a little primer? I know this is your life, right? You spend years, maybe even decades on kind of this whole ethics things. But can you just give me a basic primer as a medical student, as someone who's going to be entering the field of medicine, as a doctor, it's crazy, soon. What do you think about? Is there a stepwise step maybe in this specific situation ethically that you think about?
Right. So that's a great question. I guess another misnomer about ethics consultation is we just kind of all make it up.
Yeah.
Like we're smart, good people. We hear a case and like
just make the decision.
Yeah,
Your
like it sounds
right,
about right. Right. But there's actually a process. As I mentioned, there are several common ethical problems that come up. I would say of the three I mentioned, that constitutes probably about 70%, 80% of ethics consults in not just our hospital, but in most hospitals. So there's a process for it. There's literature behind it, right? There's even certification now in clinical ethics, which I can talk about a little bit. So it is a discipline, and it is not just made up. There is actual process. You can actually,
like a flow chart?
Well, I don't know about a flow chart, but maybe. Yeah. But you could look at an ethics consultation, at least a specialist could say, oh, that was a good one. That was a bad one. The process was followed. There's a lot of art to it as well, right? I mean, you really have to be interested in listening and active listening and mediation.
Yeah.
So there's a lot of art to it, but there's definitely more and more a sort of process and discipline to it as well.
Because I mean, I'm thinking step 2 questions and stuff like that. I'm thinking the first question, when it's something like this case that we were just talking about, you think if you know what the patient wanted, then you go with that decision, right? If you don't, again, you're gonna cut. I'm making broad generalizations here, of course.
Yeah, that's.
But I'm saying this because I'm just wondering.
My answer to that would be: do we really know what anyone really wants? Do you really know what you want?
Oh, gee, and is that the answer that you give to the doctors? I'm just curious. So I'm curious if it's too kind of, if these answers go too many different paths depending on the scenario, you can say, listen, let's not talk about this. But I'm wondering because you said there's a kind of a certain way you think about things generally. Maybe we can address this specific thing. Is there a first question you ask and a second question you ask?
I mean, again, it depends on the situation. It depends very much on the situation. Okay. What I always try to focus on is 99 times out of 100, there's a conflict between something and something, right? Either it's a conflict between a patient and a family, it's a conflict between 2 staff members, it's a conflict between 2 goods. What's the conflict? So that, I guess, the first question I try to ask or try to figure out is, what is the nub of the conflict?
I see. And then I guess you start to identify kind of the both sides' points of view. Okay. And then maybe you bring your own expertise and say, listen, here's the benefits and cons of this side of you,
right,
and here's the pros and cons of this side of you.
Right.
I see. Okay. And I'm just wondering, as an IM resident, when does it make sense to bring in an ethics consult?
Well, I think what I encourage and when I talk to residents about this, most ethical dilemmas are really, the purview of just the practicing clinician, right? And they can be managed. It's when it's a little bit more complex, or sometimes you kind of know what you want to do, but you don't want to take that decision completely by yourself. You want to bring in some other people so you can avoid the possibility of your own blind sides and bias.
Yeah.
Right. So that's another reason why we get called, not necessarily because the clinicians don't know what they want to do. They do know what they want to do, but they want some institutional support so they can say, look, this wasn't just my decision, but this was.
Got it. Are there any major medical issues or major ethical issues, sorry, I misspoke, that you wish more medical students or physicians or residents kind of knew about? I'm thinking from the 4, when we first learned the 4 basic tenets, right? Autonomy, beneficence, non-malfeasance, and justice. Is there anything like that you wish kind of we were more aware of?
Yes.
Tell me.
You want to hear?
Yes, please.
So, and in fact, I give a talk to
Yeah.
and you might have missed it. I don't know if I was doing it during the internal medicine clerkships, but I give a talk about patient autonomy and conceptions of autonomy. And this is sort of what you were hinting at, right? So there's this, obviously, it's the sort of most fundamental ethical conflict that we have is between our duty to do the best for the patient, right? That's what we call beneficence, and our also duty to allow, self-determination or patient autonomy, right? That's the most common conflict. And what I would say is that autonomy is tricky, right? Because what people want is very situational, and it's often changing and conflicting. And people really don't know what they want until the situation arises. So as physicians, it's not a simple matter of quote unquote respecting autonomy, because respecting sort of suggests something passive, like, the patient says this, and you say, okay.
Yeah.
Right? It's more about facilitating or promoting and getting to a deeper understanding of what people really want. I can give you some examples.
Yeah, that'd be. And I'm just thinking while you have this example, I had a patient. I didn't have a patient. I was a medical student with a patient, and she was one of the two people I had. And I remember she had critical aortic stenosis, really bad aortic stenosis, and she really didn't want to go through with the decision of kind of getting this valve replaced. And the question in my head during it ethically was, okay, we have a duty to kind of help this lady, right? She's going to have a much better life. She's going to be able to walk. She's probably going to live longer if this valve is replaced. But she's telling us, I don't want it. My question is, how much is pushing too much? How much is pushing, saying like, listen, like coming every day and saying, you need this, you should get this is going to help you, as opposed to, she's made the decision that she doesn't want it.
So, I mean, that's a deep question. I mean, I think in those situations when I assume you're dealing with like a capacitated person, I've put physicians, and there's clearly something that is highly efficacious and beneficial. I think the first thing you want to do is try to, it's not really ethics, this is just good doctoring. Okay. It's just like try to get to the root of why she doesn't want it. Is it some, fear, illegitimate fear? Is there something else at stake? Why she doesn't want to go with that plan? Yeah. And then you do that, and then you sort of exercise all your soft power of doctoring, trying to get. It's no different than trying to get your patients to lose weight, right? It's like try to be encouraging, you try to persuade, you try to, softly manipulate, maybe, whatever, to try to do the right thing. At a certain point in a capacitated patient, we have to accept their decision. There are situations, though, where I think the idea of capacity becomes very blurry. I'll give you an example. A case I always talk about with medical students is the patient with a new spinal cord injury. Very tragic situation. A previously healthy person has a new spinal cord injury. They've never imagined living with a spinal cord injury before, right? They may, in their mind, right, in the mind of an able-bodied person who could never imagine living in a wheelchair, have come to the conclusion that they wouldn't want to live as a spinal cord patient, that they would rather die. So there you're facing a new spinal cord patient. Literally, their life has been turned upside down in one day, and they or their family is telling you that they don't want to live anymore and say, take them off of life support. You, on the other hand, know that attitudes towards living with spinal cord injury change remarkably from, the first month to the 6th month. And most, are very happy to be alive, depending upon, other factors, and have quality of life scores similar to non-spinal cord injury patients. It's hard for us to imagine. So what is your duty as a doctor there? Do you respect autonomy, take them off life support and they die? Or dig deeper and try to promote a deeper wish? What's the deeper wish rather than the one that's expressed in that time?
Yeah. No, that's a great example. And this is a general question. Again, I feel like I'm doing broad generalizations, and you don't have to answer it. I don't know if you. I don't know. This is public, so his opinions will be on the internet. But what is your opinion as an ethics professional on assisted suicide?
Well, first thing I would say, aid in dying.
Aid in dying. Is that the best way to say it?
Yes.
I don't know. Okay, right. Aid in dying. We will cut that out.
Right. Well, some people do call it assisted suicide, but you sort of
you give it a connotation when you say assisted suicide.
Exactly.
Got it. Because different countries...
We're talking about physician aid in dying.
Yes, yep.
Right, right. So what was the question? What's my personal opinion?
What's your personal opinion? And again, it's hard. I know is by talking just the past 20 minutes, I know every situation is different.
Let me sort of...
Move it around.
What's the word? Sort of dodge and weave around that question and come back to it. Because it matters less what my personal opinion is. I think there are very strong arguments on both sides. I think having control over the time and means of your death is, in certain situations, extremely reasonable. And I think anyone who's had a loved one go through a life-ending illness knows that viscerally. And why should we be made to go through suffering that has maybe no point? On the other hand, there is the slippery slope. There is the idea that, there's certain things that just medicine and physicians should not be involved in because of what it does to our perception of our profession. So I think there are strong arguments on both sides. I think nationally, internationally, there is a movement to recognize the role of physician aid in dying in certain situations. And I think, interestingly, this is anecdotal completely, because just from the last couple of ethics classes I've taught with students I think there's a generational breakdown on this issue. I can't prove that, but when I bring up because this is obviously a
hotbed.
This is like a whole class in my ethics class. Some of the medical over the years, the idea has why would you not support this seems to me the prevailing view in younger physicians. Now, some of them may not have given it much thought, so it may be a sort of off-the-cuff kind of thing. But I think there's definitely a generational shift in the approach to this.
Yeah, that's really... And because there are countries that, if you look... I think it's Amsterdam or not Amsterdam, not a country. Netherlands or something like that, I think there are laws towards it, if a patient says...
Canada.
Yeah, Canada. It's interesting. I just wonder how these things are going to change. Okay. Ethics discussion, we'll put that to the side for now, because I think it's really interesting. I'm so happy to have you because I think it's great. But let's go back to critical care.
Right.
What is the best thing about being a critical care doctor?
Oh, there's so many great things about being critical care. I mean, look, I may be biased. I love what I do. Not to say I don't have like bad days or the Sunday scaries when I have to go in on Monday and then picking up a new service. But the best thing, I mean, I never come home wondering if I made a difference, if my day was productive. I mean, some days are more than others, but I make a difference in so many ways. Sometimes it's a diagnosis or an intervention, and sometimes it's my conversations with patients and their families. So I think the best thing is the impact I can make. Yeah,
no, that's great. And of course, the counterpoint to what is the best thing about being a critical care doctor is what is the worst thing about being a critical care doctor?
Well, the worst thing, I mean, it can at times be stressful, but I can't think of a medical specialty that doesn't have its time when it's stressful. There can be conflict, both interprofessionally, believe it or not. I think, one of the great things about ICU medicine is and maybe I should have mentioned this up top, is that it's a team sport, right? Like I can't do everything myself. I have nurses, I have respiratory therapists, I have nutritionists, and there's maybe the operating room, but there's nowhere else in the hospital that has really the kind of interprofessional collaboration as the ICU. And I learned so much, and it's just great working with all these dedicated professionals. So on the other hand, when you have a lot of people, can be a little bit of conflict.
Yeah.
And managing that conflict can be sometimes difficult. And then there's, of course, the conflict that can occur with patients and families because, the stakes are high.
Is the conflict within the team, like the residents, the nurses, or is the conflict among your peers, like other attendings that you're consulting?
Within the team, mostly,
okay.
Right?
It's fairly collaborative when you bring in a cardiologist or a
gastroenterologist. Just think, if you were spending all day working on a project with 5 of your best friends, right?
Yeah.
Right. There would still be conflict, and these people are not all your best friends, right?
Got it.
You have different personalities, different ways of looking at things.
Yeah, I see. So if I gave you $100 million today, tax-free, it's in your bank account, you can do whatever you want with it.
Right.
I'm going to give you 4 options.
Okay.
Option number 1 is you continue practicing full-time, exactly what you're doing. Option number 2 is you switch your career a little bit around. You start working part-time, maybe. Option number 3, you switch careers entirely. Maybe you become an ethics professor at Harvard, or you become the best tennis player in the world, because you can do that now. I see it in you. Or option number 4, you quit entirely and go live on a beach, hang out with your family, anything like this.
Honestly, number 2.
Number 2.
Yeah, I mean, I really, I would think I would probably buy down my time, clinical time, a little bit more, flex up on the ethics. Maybe there are a lot of other experiences. Maybe take a sabbatical or something like that. If I could do that. Although I couldn't do that anyway because of the kids in school. So I honestly look. I mean, it's the happy inverse of the spinal cord patient, right? Right. In that I don't truly know what I would do until I had it.
Yeah.
But I like to think, and frankly, I believe, although I could change, I believe that I would not make any major changes in my life.
Yeah, I see. Why would you bring down the clinical time?
Just so I could do some more other things,
Got it.
Yeah. But I wouldn't stop being a critical care doctor at all.
Got it. Okay. Where do you see your future? Where do you see your career going? Where would you like your career to
go? Well, they're sort of different. I think the traditional and this, again, listen, for medical students, this is hard to relate to because they're very much at the beginning of their career.
We all think about we all are like, we want to be the most successful, the best people. We want to have the best careers. So I think a little bit of and it's probably, I think, there's good and bads to it, right? I think you should always plan ahead. Right. But sometimes if you stick to your plan, given variables that are telling and data that's saying, you really shouldn't do this, especially in personal experience, you should not stick to it. Yeah, that's my mini spiel. Sorry, go ahead. So where
I mean, I think it's sort of hard to relate to, but what the hell? I'll mention it. Again, I didn't even know I wanted to be a doctor, and I didn't even know I wanted to be an intensivist. Exactly. But once I decided that I wanted to be an intensivist, and more specifically an academic intensivist, when I envisioned where I wanted to be, it's where I am now. Yeah. So, in a way, I've done what I wanted to do. So I want to keep doing more of it, and I think there's a natural progression that just as you to want to assume some more leadership, not for ego per se, but just because you feel like you can affect more people that way, and you feel like you have something to add. So, maybe perhaps some more leadership in the ethics realm. As far as critical care, I'm actually pretty happy with my role right now in the university.
How did you get interested in? I guess why are you so interested in medical education?
Oh, well, I think I enjoy teaching. Yeah. Maybe that's because I like hearing myself talk. I don't know. I enjoy particularly medical teaching because it's very much interactive sort of teaching. It's more like coaching is teaching. For a lot of just the way medical education has, particularly in the clinical sphere, has developed over the years. So I find that really rewarding. Yeah. I like taking complicated concepts that I had to really struggle with to understand. Yeah. Like my understanding of physiology did not come easy, right? Yeah. But I think because of that, I'm very good at breaking them down and teaching them to novice learners. And I enjoy that very much. I enjoy taking a complicated concept and teaching it to students and residents. So I get a lot of joy out of that. What was the question? Why else do I?
You pretty much answered. Why interest in medical education? And I guess how
and I
did
think,
you?
when it's, I'll tell you the other thing.
Yeah.
It's just so important.
Yeah.
It's so. I mean, who's going to take care of me, or who's going to take care of my patients? Right. I mean, it's about being part of this. I guess one thing I want to stress, and I think is, if you go back to why I became a doctor, Zach, or why I changed it. You're part of something that's so much bigger than you. You're a part of this profession. You're a part of this history. You're part of something that will always be there as long as this, right? Yeah. And just like giving back to that and moving it forward and training the next generation of physicians is just so important.
And it's so true. Because I mean, maybe it's just Jefferson. I hope it's across America, but I've had the best experience with teachers and professors and mentors here in medical school than I've ever had in my entire life, outside of undergraduate, I did a post-bac course as well, outside of everything. I mean, it seems like you guys actually really care and you really want to help us. I hope it's across the country, but just in my personal, again, anecdotal experience at SKMC Jefferson, you guys are always here for us, always, and you specifically have helped me out. I mean, I'll bring this up because I think it's possibly interesting as well. When I first started this YouTube channel, when I was talking about things on the internet, I actually pulled you aside and I talked. Would you mind? I'm going to ask you the question again that I asked you, I think, a year ago now. Posted this crazy. What do you think about medical students posting things on the internet about their medical education, maybe even about their hospital experiences?
So I remember very much when you asked me that, and I spent a lot of time thinking about it. So on the one hand, right, it's no different than you like writing an essay or publishing an article or writing a novel about your experience, right? It's the same thing. On the other hand, the medium is different enough that it made me think, is there something about the medium that needs to be considered as well, right? Because it's so immediate.
Yeah.
You're writing a book and like it could take you years to get it published. Even if you're posting in a blog, it's different, right? I don't think intrinsically. I mean, first of all, I think it's great, right? No, I mean, you can reach so many people, and like I love listening to podcasts as much as the next guy. And I think doctors sharing their stories is just interesting and fun, even for non-doctors. Yeah. So baseline, great.
Got it. Yes. Hit me with the con.
No, I don't even know if it's a con. It's more of like a consideration kind of con. Is that, information just gets out there so quick and it can be disseminated so large, so diffusely. What does it mean to be talking about patients' stories in that format, right? Like, it's very unlikely I'm going to write an essay in the New York Times and my patient is going to pick it up.
Yeah, right? Yeah, exactly.
Right? But it's possible that your YouTube video would somehow get to them. Or what does it mean not even for your patients, but for non-professionals to see you talking in that form? Does that affect their perception about confidentiality and maybe the seriousness with which you view your experiences? Yeah. So it's not a con. It was just a consideration because the medium is different.
Yeah, no, and it was really, I love talking to it about this because I think it's really helpful to me because it almost made me think about, wait a second, when I was first doing this 2 years ago, and when I talked to you a year ago, I was like, wait a second, this thing I'm doing might have an impact on real people, right? I guess that's one of the reasons I wanted to do it in the first place. Right. But I never imagined it would get to this level. I never imagined this many people would watch it. And just thinking about it, it's crazy. And it's crazy as medical students, we can actually have, and we do have, impacts and real changes on patients' lives, right? So it's crazy.
It's more like a consideration. I think since the medium, look, what you're doing in a sense is no different than like people in the 19th century, keeping journals and sharing their experience about it. And that, in that essence, is no different. Yeah. On the other hand, I just think because of the medium, there are things you have to keep in mind about how the medium can view the message.
Definitely,
Right.
definitely. No, it's something I'll continue to think about.
Right.
And I definitely stay away from, and we talked about this as well, people have gotten in big trouble for this, right? I think
Right.
people have even been kicked out of med school for recording in the hospital, right? Never do that. I'm just saying this almost as to two other people who want to start doing things on the internet around healthcare, right?
Right.
I think you never, obviously patients are number one. Don't record in the hospital. Think about the things before you say them. I'm just trying to think.
I think it would be
Anything else?
interesting, Zach, maybe to interview some patients.
Yeah,
Have them here.
that'd be
Right?
interesting.
Have them here with their doctor.
Yeah, that's a great idea.
There you go.
I'm gonna write it. That'd be amazing.
Right? That's the other
side.
things that are maybe less spoken about.
Because when we first got to medical school, I remember we had a doctor interviewing a patient with
Right.
HIV and AIDS when we first
Right.
walked in, and it was I was like, wow.
Right.
This is so interesting.
Right.
And I think it's important too, because I think it's better now.
Mm-hmm.
I think back in the maybe 40, 50 years ago, in your first 2 years of med school, you don't have that much actual patient exposure.
Right.
It's just books.
Right.
Luckily, it's interesting. Who knows? Maybe I'll ask you for advice on where to do my fellowship in ethics and stuff like that. So is there a common myth or something that people commonly think about some ICU attendings or critical care doctors?
I think the common myth is like we're basically like saving, like every minute is some like life-saving procedure. And don't get me wrong, there are those.
Yeah.
But that's not happening every day.
Yeah.
Most of the time, if you walk into the ICU, you'd find people standing around thinking and talking and trying to make decisions about what to do in a very sort of, what's the word?
Organized?
Organized, yeah, right. And there's just enough of the other stuff to keep it exciting.
Yeah, you're not jumping into rooms every second. You do
Right,
it occasionally.
It happens,
Yeah,
absolutely.
yeah.
Absolutely.
Where do you see the future of critical care? Do you think there's any major changes? I was just talking to a surgeon the other day, for example, and they said, they think robotics are going to be
That's an
the
interesting
future.
question.
I'm just wondering if there's any major technological advances in critical care or anything you see that's changed throughout your career that are kind of big things.
Wow, that's a great question. So I guess I'm not enough of a visionary.
No.
to think about. I do, though, have this feeling often. I say this to my students and my trainees that I know, not even 50 years from now, or maybe not even 100, but maybe 50 years from now, they will look back in horror at the barbarities and the coarseness with which we practice medicine in the ICU, because a lot of the technologies, although they've been tweaked, are like the ventilator.
Mm-hmm.
Ventilator was around. Positive pressure ventilation's been around since the 1950s.
Yeah.
There's new bells and whistles, but the idea of like putting a tube in someone's throat and hooking and connecting their lungs to this machine, it hasn't changed much. Yeah. Technologies to support failing circulation, there definitely have been some improvements, particularly in the cardiology world when you talk about...
Is this ECMO you're speaking about?
Yeah, there's ECMO and bypass, all those things. Definitely been like advancements.
Yeah.
But typically in the medical ICU, the technologies we use are, again, sort of old technologies that tweak. I think the biggest changes have been in monitoring, right? The way that we get data. So I'll give you an example, right? So you're familiar with an arterial blood gas?
Yes.
Right. Okay. So right, this is a common, what's most routine laboratory investigation that you can do in a critically ill patient, right? Even in the 1970s, early 1970s, if you wanted an arterial blood gas, you had to call a vascular surgeon literally to come in and puncture the artery or put a catheter in, because no one was just puncturing, right? This was like a big deal.
Why? Because they were scared of just going to arteries as opposed to veins?
I think it had to do with the idea of puncturing in the artery, but also the technology of cannulation was just so primitive. You were using like metal cannulas as opposed to plastic, right? And now that thing has become routine.
Mm-hmm.
Pulse oximetry. Pulse oximetry really wasn't widespread, and I couldn't be a little bit long, until like the late 70s, early 80s.
Really?
Could you imagine taking care of a critically ill patient without a pulse oximetry, right? So I think the greatest advances that have been made in critical care are more in monitoring than necessarily therapeutics. The and this is how deeply technical do you want me to go?
I love deep technical.
Okay. So I think the biggest need in terms of monitoring advanced and critical care is how we assess resuscitation. So I don't want to get too deep in physiology, but the markers that we use for resuscitation are kind of surrogates for what we really want to measure, which is really how we affect oxygen delivery to the tissues. So the big advancement that I hope is coming is direct monitoring of tissue oxygenation. And if anyone wants to go deep on that, we can talk about that.
There's I'm trying to think, because this is when I was, remember, a class that I did on kind of brain pharmacology and things like this. For example, when they do, it's very hard to understand brain chemistry and brain biology, especially in humans. But there was something where they would able to actually like put in a catheter somehow into the brain and see the live what the chemical changes and things are going on. Is that kind of what?
I don't know about the chemicals, but also the oxygenation. Yes, so that actually has been pioneered a little bit in neurology, critical care, right? Because you could imagine, let's say, somebody has a stroke, and why do they have a stroke? Well, basically, they have a stroke because there was a decrease in oxygen supply. There's a decrease in oxygen supply because there's a decrease in blood supply, right? That causes the stroke. So part of treating the stroke is improving oxygen delivery. How do we know we're improving oxygen delivery? Well, we want to make sure someone's got a good blood pressure. We want to make sure that their hemoglobin is well saturated. Maybe we want to know directly what their cardiac output is. But all these are markers. What we really want to do is like have a catheter in the brain, or in my world, more like in the kidney, and know if I've improved the oxygen delivery to that tissue. Because that's what I really want to do. That's the thing that I want to change. Meanwhile, blood pressure and all that is just a sort of surrogate marker.
And jumping back earlier, we're going from clinical to things. This poem, I just remember that poem crit care thing you mentioned.
Yeah.
Why is that? Can you tell me that story? Why is
it's really
students
interesting.
have to do poem crit care?
So as I mentioned, that's a critical care.
Yeah.
Remember, and ICUs weren't really invented to the late 1950s. They were outgrowths of the operating room.
Wow.
Right? Because, the first ventilator.
Were they the PACU, I guess?
Yeah, right.
Wow.
The first ventilators were like the iron lungs, which worked on negative pressure, and that was solely for people with polio. It doesn't work for other indications. That wasn't really an ICU, right? But the ICU developed because of the technology that developed, right? So you had the ventilator, right? You could now do operations with people asleep and not breathing on their own, right? Excuse me. And some of them still needed to be on the ventilator when the operation was over. Where did they go? Right?
Special package. No.
Right. So they went to a place that was staffed by anesthesiologists, right? And some of them may still be in shock, and some of them may still be in shock for a couple of days. So who's going to take care of them? Well, probably that anesthesiologist, who's there. The other place where ICU came from was cardiology, right? So as the number of interventions in cardiology started to increase with catheterization, you needed a place to put these people after their interventions. So the cardiologist would come.
I see.
But these people didn't really think of themselves as intensivists. They thought about themselves as anesthesiologists or cardiologists, sort of taking care of critically ill patients. Then the technologies, the number of ventilators exploded, and you're like creating rooms full of people on ventilators, and you got to have somebody who takes care of those people. So the old model was like, well, who knows something about breathing? Oh, pulmonologists and anesthesiologists. So they would come in the morning and see their patients on the ventilator, go back to their clinic and see patients in the clinic, and then maybe come back in the afternoon, and the whole place would be run by nurses.
I see.
Or maybe the unlucky house staff person who would secret and not know it, right? So, and then over the years, we're like, whoa, like this is becoming, there's so much stuff here to learn, there's so much knowledge that we need to create a sort of specialty in it. And then later, the idea that you could just make a job out of that sort of came later. In the United States, probably because of the centrality of the ventilator to critical care. Pulmonologists sort of latched onto that. They realized that, hey, we're being called in to do this anyway, and they sort of created this idea of certification in critical care, and that became the major pathway to board certification in critical care was through a combined pulmonary fellowship. In Europe, the primary pathway towards intensive care is anesthesiology.
Interesting. So do they do, I guess their specialization is like anesthesia critical care?
Yeah, exactly.
Ah.
Exactly right. And that's still the case in most surgical ICUs in the United States. But in the medical ICUs, it's usually an internist, pulmonologist, or an internist like myself, critical care.
So before ICUs, when people were really, really sick, were they just on, like, were there 3 floors? Because I think of 3, there was just 1 floor, I guess.
Yeah, what were you going to do differently? And then, like in 1930, like you had someone coming in with respiratory failure for pneumonia. What were you going to do?
Give them a nurse that's with them only.
I don't even think you had oxygen reliably to provide. Right, so the care of that patient looked like the care of the less sick patient you would now have on the floor.
Oh, wow.
So it is especially born of technological advancements rather than say, nephrologists, there was always a kidney. Although actually I would say, nephrology probably became more of a specialty when the dialysis machine was invented.
That's really interesting. I never think about that, the technology driving the creation of
absolutely.
specialties.
100%, right? You think of, what's another example? I mean...
the nephrology dialysis, that's crazy.
Right. The gastroenterologist, as you mentioned, right? I mean... There were internists who were always interested in gastroenterology.
Yeah.
They never would have identified themselves as gastroenterologists, right? But then, along the way, you had more and more knowledge about gastroenterology. Probably people writing textbooks just on gastroenterology, and then the endoscope comes along, and now you have a procedure. So now you have a procedure that you have to become competent in, right? This is how guilds are built, right? So that's how specialties evolve,
That's really cool. So let's say I'm a medical student, right? And I'm not really sure if I want to do critical care or not critical care. Let's say, critical care. Let's say I'm already thinking about critical care, maybe as a medical student or maybe even as a resident. How do I decide that I want to do, the critical care should be the specialty for me, I should go and this should be my life? Should I do more shadowing? Should I do more research? What's the best way to go about deciding for me?
Well, I think in all of the primary, and I say the sort of core residencies, and I'm talking about surgery, pediatrics, and medicine, right? You will have exposure to ICU. So you'll get some taste of it there. And if there's a signal that you may like, then you'll probably do some more rotations there, start to talk to people about it.
Got it.
Yeah.
And as the director of this fellowship program, if I'm a resident or even if I'm a medical student and I want to be the most competitive as possible, I want you to look at my application and say, you know what, this guy, we got to have him. We got to put him at the top of our rank list. What should I do?
Well, I guess a lot of it's generic. Just work hard, read a lot, get good letters of recommendation, be a good person, be a good doctor, and that will come through. Research. I have my own take on that. A lot of medical students are obsessed with how many publications do I have, and I think perhaps I'm an internist. I don't know if this is. Perhaps if you're applying for neurosurgery residency, that makes a difference. To me, what I want to see is just a scholarly attitude, and that can manifest in different ways. That things you produce. I mean, this is a kind of a scholarly in a way, right? You're showing that there's something. You're interested in something other than just that patient in front of you. You're interested in something bigger. And so when I look at scholarly potential, it's more that rather than, you had 5 posters and 2 abstracts and stuff like that.
Got it. So it's kind of showing this
I'm not
interest.
sure all fellowship directors feel the same way, but that's what I look for.
No, it's a helpful answer, and we'll put this out to the applicants next year, and they'll all be starting YouTube channels and podcast, and then they'll be doing their things. The next question I had is just more general advice, because the career of medicine, the career of healthcare, isn't the easiest field, right? We work kind of hard, we have long hours, we go through a ton of training. Do you have any general advice for medical students or people entering the healthcare field to have kind of a good life? I guess it's a big question, but anything, it could be lifestyle, it could be finances, it could be anything, relationships, anything at all.
I'm definitely not going to give relationship advice. Well, I think I'd start by saying that, medicine is great. I think sometimes medical students will run into people who are not happy in their career, unfortunately. I'm sure that happens in anything, but most of us, I think, believe that we are so blessed and lucky to be in this opportunity. So that's number one. Don't forget that. I mean, number two, I think, there's this debate about, well, do you follow your passion or make some sort of calculations based on other things? And I like the stew analogy because I don't think it's an either or. Personally, I think it's very important for students to remember that even in any given specialty, the balance of work life can change, is so heterogeneous based upon particular practice setting. As far as residency goes, they're all probably a general surgery residency is probably like a general surgery resident. But as far as what is going to be like to be a general surgeon or an obstetrician, it varies so much. It's almost like, I don't know how much weight to give to that.
Yeah, I see.
And to me, personally, you have to do something that you find compelling because I don't know. I certainly could be. I don't think you're going to be happy if you're not enjoying the thing.
Yeah.
You might still be unhappy for other reasons, but you're definitely not going to be happy if you're not enjoying the thing you're doing.
No, that makes complete sense. And then you're a big writer. Are you a big reader as well?
Mm-hmm.
You're a big reader. Do you have any books that you can recommend? This could be to people entering. Some think books people mentioned in the past. House of God.
Yeah.
When Breath Becomes Air.
Right.
There was another book by the same guy that wrote one of the whatever. They wrote about his surgical kind of checklist and things like that.
Atul Gawande.
Atul Gawande, yeah. Any books that...
I love those all of them. But
yeah.
So to the humanities major that is like deciding that they don't want to become an English PhD and thinking about a career in medicine, read Somerset's mom's Human Bondage.
Somerset's Mom.
Somerset Mom.
We'll link it. Yeah.
It's just the idea. I mean, to me, that was of Human Bondage. It's an old book.
Yeah.
It's kind of antiquated in some ways, but that was like, oh my God, like this is what, like, if you're a humanist kind of guy and why you should be a doctor, that one.
That's awesome.
If you're a resident, another one, and I think every resident should read this, is Abraham Verghese's In My Own Country, which is a story.
In My Own Country.
Right. Well, of Human Bondage takes place in like the 1920s, I believe, and it's basically
I'm writing these down.
About a young person finding themselves and through medicine, I think, and a lot of other things. Verghese's In My Own Country was written in the early 1990s, and it was about Verghese's experience taking care of patients with HIV in rural Tennessee. It was really interesting because he was a foreign medical graduate, and then doing a J-1 visa, it got plopped into Eastern Tennessee, and started seeing really some of the earliest cases of HIV, and a lot of his patients were gay men who had left Tennessee, right, because they weren't accepted as gay men, went to New York, San Francisco, Los Angeles, got infected, got sick, came home. And he talks about that experience. It's just like, it's an amazing historical representation of the early days of the HIV epidemic, which I think every current medical student needs to know something about. And also, it's just an amazing story.
Yeah, yeah. Something I completely forgot to ask, and I can't believe I didn't write this in one of my question lists, is COVID. Right? You have
we
been,
could do a separate episode on COVID.
I guess the one question I have, and then again, you can expand on this in any way, shape, or form, because you were at the front lines here, right? When this whole craziness has been happening. I guess the question I have is, how has your practice changed? And we don't have to get into specifics around kind of medicine and things like this, but how has your practice and maybe the way you practice medicine changed since this whole pandemic?
Well, I think it's gotten back to where it was mostly. I think.
And if you have anything you want to talk about the whole COVID thing at all, I mean,
it was. Look, when I'm like on my doddering around with my grandchildren, hopefully, please God. I'll be talking about COVID, right? There's a lot of the ways like Abraham Verghese will be talking about the early days of the HIV epidemic. It was you had this feeling that you were, living history, right? So that I don't want to put it the wrong way. It was scary and exciting at the same time.
Yeah, no.
Of course, I always joke, like, if the pandemic went on for like 3 months, it would have been awesome. It just went on a little bit too long. Like, we were at the center of attention. It was really exciting. It was a new disease. Like, how often is there like a totally new disease? Everyone was writing. Everyone was like, I was like, I remember in March, like literally calling up ICU doctors at NYU in New York as they were getting their first patients, and we had our first patient, and I was like, what's it like? What are you doing? I was like, I would never pick up the phone and just call a random doctor. Anyway, that's what we're doing. So there was this like, again, you were part of history. But it was also scary, right? I mean, it was, because I definitely don't want to diminish the human tragedy of it. I mean, I remember having, literally, so normally, I say at Jefferson, we have 17 ICU beds. Yeah. And I'd say on a normal day, like 4 or 5 of them are on a ventilator.
Got it. Yeah.
At the height of COVID, every single bed was someone on a ventilator.
Wow.
And we had overflow up into the next ICU.
Jeez.
And they not only were on ventilators, half of them were on dialysis.
Wow.
And another 60% were on vasopressors.
Wow.
I mean, it was the sickest bunch of patients I've ever taken care of.
Wow.
And sometimes it felt like there was not much you could do for them.
Especially in the beginning, right?
Yeah. And I was taking care of people that were not any older than myself. Additionally to a lot of older people, but young, healthy people. And that was really, really emotional and scary. And the families weren't allowed to come into the ICU, which was like, that was end of life situations where people were allowed to come in and look through the glass at their dying spouse. I mean, that was pretty horrible.
Crazy. Do you think have you learned any lessons? Have you taken anything from it that you're gonna apply going forward?
Well, I mean, I learned some more stuff about how to manage a patient with ARDS. And we learned some interesting things, I think, about lung physiology. I think we learned the benefits and pitfalls of how we create scientific knowledge in real time, right? I mean, this was the first, I don't want to say it was the first YouTube disease. It was the first,
social media disease?
Yeah. In a sense, even in medicine, right? You had all these like, people were just like, I had a patient and I'm going to write it up and put it out there. And I had 2 patients. I'm going to create a case series. And I did this and they got better. So maybe like this is a thing. Yeah. Well, maybe it is. Maybe it's not. Like, and people were publishing what you call preprint articles. So like a manuscript is under review. I mean, preprint, I think the idea of preprint publication was already out there, but it like took off with.
Is this before like peer review? Like
exactly. So you have an article, you submitted it to the journal of whatever. It's under review.
Yeah.
So it hasn't even been peer reviewed yet. It may not even be published, accepted, but you put it up on some sort of server. Now, on the one hand, that's great because the peer review process takes a while, and if you got really important information, I want to know it now, right? This is happening in real time. On the other hand, then you had to go back and sort of like separate the crap from the good stuff, right? So, and there was, obviously people are aware of the different disinformation and stuff that was out there. So I think that was something we learned about scientific knowledge and how, and the other thing was it was worldwide.
Yeah.
Right. So it wasn't right. So everyone, you're like reading stuff from China and from Italy and right. So the next pandemic will
you'll be ready.
Right. So that was very interesting.
Sorry to interrupt, but it seems the numbers. So I was looking at the Medscape numbers on happiness and burnout, specifically EM doctors and critical care doctors. It seems their numbers jumped maybe 10-15% of self-reported burnout. Did you feel any more burnout or burnout at any time during this pandemic?
I like to joke that I gained a couple of pounds because of all the cake from the going away parties at the nurses. I think there was a lot of turnover. I mean, I think it brought some things to a head in people that were, I don't know what the word is, pre-burnout, There was, look, at the beginning of the pandemic, again, I don't want to minimize this. It was a horrible, horrible time. But in some ways, it was a great time to be an intensive care doctor. Yeah. Right? I mean, like, people were banging pots and pans outside for us when we walked home, right? And,
it's almost like going to war, it felt like exactly. A little bit. It felt like people coming together.
100%. And, like, I would tell you, like, the food that got sent in every night was like a bar mitzvah every night in the ICU. Enormous spirit of collaboration and right. And then there was this like letdown as it dragged on, and 2020 was also a pretty tumultuous year in American life. People used to ask me, Dave, how are you doing with and I said, like, the hospital's fine. It's the rest of the country that is making me depressed. Yes. Right. So, I can't separate. That was like George Floyd, the election. Like, in my mind, they're all kind of like rolled up together. And I think, so there was definitely a malaise that.
But you never think you got to the burnout point, or do you think you would?
I think I guess my one problem with burnout is that it's a very non-specific term. It means a lot of different things.
I see.
If
someone asked you on
I'm not doubting its existence, but the problem I have when we're talking about burnout is like, it's like dizzy. Yeah. When a patient says, I'm dizzy. Yeah. Like, well, they can mean like 6 different things by dizzy.
7 neurologists just had a stroke when you said that, so it's good,
Right? It's like, right? Yeah. Do you mean like, and I think burnout is similar.
What should we do with it? What should be the question we ask physicians?
I don't know. Yeah. I don't know. I just, there's something I noticed that I feel like sometimes, burnout is a syndrome, obviously, has many different causes and many different manifestations. And all I'm saying is, I think sometimes when we say, oh, I was burned out, I'm like, well, okay, tell me more. What exactly does that mean? Are you not finding enjoyment? Is it just in your work anymore? Is it the particular work situation that you're in? Is it the hours? Is it the pay? Yeah. Is it, what is it, right? Is it stuff at home? Is it the combination of both? So I just think it's hard because it's a little bit imprecise.
Very general. It's kind of the theme earlier when I was asking you, should we do, what is the proper term? Physician-aided?
Aid in dying.
Aid in dying. Okay, I know aid in dying. So let's get more general. Let's get even back into Dr. Oxman's life. If you were speaking to your 18-year-old self, would you give him any advice?
Your 18-year-old self? Wow. Maybe I could talk better to my 25.
Or even the first year of medical school self.
Okay, let's do that one first. Yeah. Well, what I would say, I was acutely aware of this because I was 29 and
Yeah.
I'd done other things. I was so thrilled to be in medical school. I would just say to first-year medical students, like, this is just an enormous privilege that you have. And if you don't see that, maybe this isn't the right thing for you. It's just, in so many ways, not only are you going to have an exciting and remunerative career, but you're also viewed in such high esteem by most of society still. You have just a special place in like people's imagination as a doctor. So just remember the privilege. And chill out a little bit, you know, like, I know it's hard, med school selects for a certain type, right? You know, it's mostly all going to be okay.
And it's and people say that all the time. And I think when I was a first, second year med student, I was like, please stop telling me that. Like I don't believe it.
Right.
Like I'm dying here. I am drinking from the fire hose. I'm doing all this. But as a fourth year medical student, and as you, who's now accomplished in your career, I think it is true. These things really do work out, and they're saying it as a specialty. And the second one is in general.
Okay.
So first one.
Yeah.
Do you have any closing words for people who are interested in critical care as a specialty?
In terms of like whether it's right for them or how to do it?
It's I guess kind of saying like, say they're a little bit interested into it.
Okay, so I think there are certain things about, like, I think these are broad generalities. Like, you know, you take ophthalmology. I'm sure there's like many different reasons why people went up. Maybe not many, but a couple different reasons why. So ophthalmology. One of the sort of decisions you have to make, let's say you're an internist about a subspecialty, is like sort of generalist versus, well, this is maybe even before specialty, generalist versus sort of subspecialist, right? Like, I always thought, Zach, that I was going to be a general internist. My kind of heroes were like general internists, like the wise generalists, you know, as a long-term relationships with patients, and is a great diagnostician as well as just a great human. Believe it or not, one of the things that I like about critical care, and I think it's what has drawn me to critical care amongst other things, is I'm still a generalist. Like, my knowledge on a lot of things is a mile wide and an inch deep. I still, as an internist, as an intensivist, I have to know a bit about everything, right? From rheumatological disease to trauma, right? You know, I like that, right? I like that. Some people don't like that at all. Intensivists has been called the primary care doctors of the critically ill because I'm the one coordinating. I'm the one who knows a bit about everything. I'm the one who's making diagnoses and then linking them. So I think in some case you have to ask yourself, you know, are you a little bit more of a generalist or are you a little bit more of a specialist? Some fields let you do both, right? Like, you know, gastroenterology even lets you do, you could be like a advanced endoscopist and spend all day in the ERCP lab, or you can be the more generalist gastroenterologist. So I think that's one thing you should look at.
Got it.
I think, you know, the other thing is, you know, the other thing I love about critical care, you know, it's one of those specialties where I get to stand around and blab and think a lot and get to do stuff like sort of materially physical. I like that, you know. I'm not a handy guy at all, but I
You don't build sheds and things.
No, I'm like pretty terrible. You know, because I've been trained, you think I might be, right? Because if you walked into the ICU and see me doing certain procedures and things like that, it's just because I've been trained in it, and I get a certain satisfaction out of that. But I would not want to do just that. I wouldn't just want to be a technician. Yeah, exactly right. And so I love that combination. It's very, very important for me. So that's something you should think about. You know, you also have to think about how you work in sort of pressured situations. For some people, the idea of taking care of, you know, patients who are at risk of dying is something that would repel them, and it's a little bit of a weird thing to say.
As
that
a doctor,
I was drawn to that, but I definitely was drawn to the idea of like, oh, this stuff, you know, this interaction really matters. You know, the difference I'm making sometimes can be between life and death, disability and not. So that was, you know, you have to figure out, if that's something that
That's something that's interests
may appeal to you. Yeah.
Yeah. And then in general, any closing words in general? This could be from the ethics professional. This could be from the writer. This could be from
Jeez, it's a little bit broad.
the not deciding on medicine until you were 28, 29 years old. Anything at all.
Well, I guess this could be kind of general, but let's make it also specific to the medical student worrying about what they're going to go into.
Yeah.
I strongly believe that it's not the choice between like eternal happiness and eternal misery. Like, oh God, if I get this one wrong, I'm destined to like be just miserable. I think there are many different ways to be happy. It's not necessarily either or. There are probably different ways to be happy. So if you're one of these people who's torn between radiology and psychiatry, those people exist. So, remember that, people are complex and you will find your way in no matter what you choose. So don't necessarily worry too much about that. And one specialty doesn't necessarily lead you to misery if you've chosen the wrong one. But then also don't be afraid to change. And I went off the path. I had to create my own pathway. And now there are fellowships combining infectious disease and critical care. There really weren't when I was. And so don't be afraid to go off the path a bit too. It can be hard because it's always easier to stay on the path. But now this is sounding like really general advice. But if your heart is calling you to go off the path, go for it.
Take a look at your stew. I love this stew thing.
Yeah.
This was fantastic. Well, this has been fantastic. Do you have any plugs? Do you want to put your Twitter, your Instagram, your YouTube channel, your podcast that's releasing in February?
I need to get more social media connections, and I don't, unfortunately.
Well, this has been fantastic, Dr. Oxman. Thank you so much for coming.
Zach, it's been a pleasure.
Thank you. Perfect.